of the vascular or the cardiomyocyte cells. And we majorly study that the first that the myocardial cells can be classified that autonomic the cells and also working cells. And then we will majorly that study that the pacemaker. The pacemaker cells the electrical action potential. And here I hope master the mechanism of the signal arterial node PCL, the action potential formation. This action potential, majorly action potential formation first know that this the signal arterial node PCL can be classified three phase, the phase 0 and phase 3 and phase 4. And the phase 0 is majorly because that the calcium air-tapped calcium channel open, and then this calcium influx. And also there are air-tapped channel open. Its threshold the potential is negative 40. And also then the membrane potential depolarized to the threshold potential negative 40, and then the calcium channel open, and then calcium influx. And the calcium influx, and then we will know that this the action potential is that depolarization. And also the even reach the zero. And at the same time that phase 3, majorly that calcium channel closed, and then calcium channel influx decrease, and then the potassium channel open, and then potassium outflow. Then we can see here this action potential is actually is recovered to the repolarization. And also repolarization then makes the repolarization potential, and then it not unstable. Then there is no the action the resting potential. There is this potential, we call that maximum the repolarization potential. And then because it's not unstable, and then it is also that he slowly depolarization. Slowly depolarization, we can see here that majorly that because the phase 4. The phase 4, because that majorly that major effect because the potassium outflow is progressive decreased. It decreased that especially that is the major effect. And then compared to that the calcium and the sodium influx. And so here that this during the phase 4 then shows that the signal arterial node PCLs show automatic depolarization. Then this automatic depolarization reach the threshold potential the negative 40, and then due to the L-type calcium open, and also then the 0, 3, 4 and 0, 3, 4. So here we can see here that this cell that haven't received other stimuli, but it can depolarization by itself. Then this we call that we will study that this depolarization is because not have received any stimuli, but then this can slowly depolarization is by itself. We call that this is also that automatic depolarization. Yeah. So here so here we have know that the during action potential the phase 4. The phase 4 have or no have an ability automatic depolarization, and then we can classify these cells two types: one automatic cells or non-automatic cells. Yeah. So here that we classified these two types majorly based on the automatic have the automatic depolarization during the phase 4. Yeah. Here, understand?
Understand.
Yeah. So that if you tell us this or face this choice, and also then I hope choose in the exam. I hope you know how to choose this answer. First, that based on the automatic depolarization, and then we can depolarization during the phase 4. Then we can classify the cells into the automatic cells or non-automatic cells. Yeah. Then these cells can automatic depolarization during the phase 4. Then we know that this cells is automatic cells. Yeah. Okay. And then we also have studied that ventricular cell. Ventricular cells majorly that we have known that his majorly function that his function majorly the cardio such properties include that contractibility and also excitability and also their conductivity. And then this major properties is that contractibility, and then this also we call that is working cell. And then the ventricular myosite action potential based on the resting potential, and also then these cells received the excitable informations. Excitable informations can be conducted from the signal arterial node P cells, and then this depolarization. And then depolarization, we can know that this is the ventricular myosite cell action potential can be classified 0, 1, 2, 3, 4 phase. And also we can see here that during the basic resting potential and then depolarization. Depolarization also we can see here they're very fast, and also that amplitude is a high amplitude. And about we can see here from the resting potential negative 90 and even to the positive 30. So here we can see about that this is 120 millimole value. And the phase during the phase theory, we have known that this is majorly that the fast sodium channel open. The fast sodium channel open, we have all know that the fast sodium channel, this resting potential is the negative 70. And then this depolarization reaches the negative 70, and so the fast sodium channel open. And then this then lead to the sodium fast influx, and then lead to can shows that the this action potential is depolarization, and even overshoot the positive 30. And then we have known that channel well targeted gate channel. So here that this channel open or close be created by the membrane potential. And also then we can see here that then to fill phase 1. Phase 1, and then this faster sodium channel close, and also that this is the potassium channel open, and also potassium outflow. Also that outflow we can see here. This is the action potential shows the repolarization and repolarization. And then phase 2. During the phase 2, we can see here the membrane potential is keep balance with the 0, 0, 0. And then also we call that the plateau period. And there, during this phase 2, there are two ions channel open. First, that calcium influx, and also the potassium outflow. And the calcium influx and the potassium outflow keep balance. So here that this the memory potential keep the 0. And also then continue to the phase 3. Phase 3 majorly that because the calcium closed, and also then calcium channel closed, and majorly that the potassium outflow. Potassium outflow and recovered. We can recovered to the resting potential, or also that this is depolarization. So here we can see here that, and also then depolarization reach also then reach and then reach to the resting potential, and we can see here that the phase 4. During the phase 4, because before phase 4, then there is because the sodium influx, potassium outflow, and calcium influx. So here need to the ion concentrations inside or outside the membrane happened the change. So here they are like that. Inside the potassium, inside the sodium and calcium increase, or outside the potassium increase, and then this is also activate the like that the sodium and potassium pump, and also the sodium and calcium exchange, and also the calcium pump in, and then so here that the phase 4 majorly this is potency activity, and also then like that calcium sodium and potassium pump, and then need to that the sodium 3 sodium after the cell, 2 potassium in cell, and so on. So here we also can see here that the action potential of the ventricular myocyte, that we can see here, this also be divided, also be composed by be made up of the depolarization and eupolarization. We can see here there also the depolarization is very fast, and also then based on the phase 2 based on the phase theory, if the faster sodium channel open, and then need to the faster sodium influx, and then also we can see here depolarization is very fast and amplitude is higher, and we call this is the faster responding cells, and others, and also then this is majorly and now we know that this action potential include that depolarization or eupolarization, or we can see here this eupolarization have a longer durations, and also we can see here the time is longer. Yeah. The next class we will talk about that this 2 type of cells, the action potential or memory or the transport memory potential. I hope you understand and remember. And then we just talk about that also this according to the phase theory. If the sodium in some cells because they are faster sodium channel open, and then lead to the faster sodium influx, and then this lead to depolarization, and then we call this is the cells is faster responding cells. But all other some cells and these cells also include that ventricular myocyte, and also some that other cells like that we can see here. These major 2 cells I hope you master, and also other cells you know that, okay. Yeah. And also like that we can see here the Purkinje cells. Purkinje cells we have known that the potentials of the Purkinje cells. Also we have known that like that this is the ventricular myocyte we can see here. Yeah, we just talk about that. And also then this blue wave is that is a Purkinje cell. Purkinje cell we have known that Purkinje also that is also that the also automatic cells, and then we can see here that his memory potential also can be classified that 0, 1, 2, 3, 4. We can see here. Can you tell me these two cells potential same or different? Who can tell me? Yeah. This red curve is the ventricular myocyte cell action potential, and the blue is the previous cell's memory potential. Can you tell me? Different or the same? Yeah.
Different.
Very different. We know that also that the ventricular myocyte cell action potential also can be classified 0, 1, 2, 3, 4. And then we can see here that the Parkinson also can see here that it also can be classified 1, 2, 3, 4, 0, 1, 2, 3, 4. Then can you tell me which different? Where different? Hmm? Who can tell me? Which
Oh, sure.
which face different?
I think it's almost same, but in the resting potential,
Yeah,
it
very good. Yeah,
different.
you think about that which state different, which phase different?
Resting potential
X, X potential.
in
Yeah,
the phase 4.
very good. Phase 4. Yeah. Just that you also answer the answer think about that the phase 4 different we can see here, and then according to this curve, and you have found that this two type of cells, the action potential or the memory potential is different, is majorly that the phase 4. Yeah, very good, very good. And also we can also, according to there, we can see that the 0 is major like the same. Yeah, we can see also the fast. Yeah, and only that this level is lower, but there we can see also that is very fast, the 0. So here, both the Purkinje cells and the ventricular myocyte is during the phase theory. Also that because the faster sodium channel open, and because that the faster solar influx, and then this we can see here this depolarization very fast, and depolarization aptitude is higher, aptitude higher. So here the 0 is majorly that the same, and also the 1, 2, 3 all the like the same. But we can see here the phase 4. The phase 4 we have just studied that the ventricular myocyte we can see here during the phase 4 is also we call the recovered to the resting potential, also the stable. But then this majorly that this stable, and only that the bump activity, and also then keep the ions recovered to the resting potential to AC. This is ventricular. But then we can see here, this is the Purkinje cell. We can see here, this phase 4 stable or unstable. Yeah,
Unstable.
unstable. Very good. Yeah. So here we can see we according to this curve, we found that this during the phase 4, this Purkinje cell is unstable, and then we know that according unstable. Also, we can see here in which situation. Here we call that this we call that this in which situation this phase 4. Yeah. Phase 4, we call that, according to that, we can see here, this depolarization or repolarization. Yeah.
Hyperpolarization.
No, not hyperdepolarization. And there we call that this is majorly that this is depolarization. And then this depolarization also that we have known that this is cells not received any stimulus, but is polarization is by itself, and then we depolarization by itself. So we call that is automatic depolarization. And also then like this also phase 4. And then according to this, we can be classified based on the zero or phase 0, the depolarization fast or slow. We or depolarization channel open, potassium channel or sodium calcium channel or sodium channel open. And then we can classify the cells, the faster responding cells or the slow response cells. And also then according to the phase phase 4, the cells can automatic depolarization or non-automatic depolarization. We can be classified that the cells automatic cells or non-automatic cells. So here we can see here this potential is not only is both the faster response but also the automatic. So here that potential is a faster response and normal cells or automatic cells. Yeah. And then we have talked about that this majorly that the potential cells potential. Potential that also can be divided into the phase 0, 1, 2, 3, 4, and 4. And also that the 0, 1, 2, 3 is basically similar to the ventricular myocyte cells, and also the mechanism similarly too, but only that the phase 4. The phase 4 is different. The phase 4 we can see here, he can automatic depolarization. And also then when the automatic depolarization reach the faster sodium channel threshold, and then the faster the depolarization. Here that the phase 4, during the phase 4, the Purkinje cells that majorly include two types the ions flow. First, that this is incidentally sodium influx, and also second that the potassium outflow decrease. And in here we can see here there is only that the sodium influx and also the potassium outflow. So here that this also the during the phase 4 is according compared to the sinoatrial nodal cells. We also found that during the phase 4 it's also different. The Purkinje cell is also different from the sonor artery cell nodal cell. The sonor artery nodal cell during the phase 4 includes three ion flow, the sodium and sodium influx and the calcium influx and the potassium outflow. And also we can see here, then according to the Purkinje cell and the sinoatrial cell, can you tell me which is the during the phase 4 depolarization fast? Yeah. Who can tell me? We know that the phase 4 Purkinje cell include two types of flow. One sodium influx to the potassium outflow, and also they need to the no automatic depolarization during the phase 4. And then according to the sinoatrial nodal PCLs, we have studied that during the phase 4, he majorly that include the three flow. Sodium influx, calcium influx, and potassium outflow. Then can you tell me that depolarization phase 4, which depolarization speed is fast. Purkinje or signal arterial, not PCL. You think about?
Purkinje cells.
Purkinje fast or signal arterial cell fast? Yeah. Phase 4.
Yes or not?
You think about that? Which Purkinje or the signal arterial cell? Yeah. You think about that? Okay. You think that? Yeah, very good. Signal arterial node, and we can know that according to this mechanism, we think first think about that because we can see here this only two. Potassium outflow and sodium influx, but the signal arterial node include three. Not only the sodium influx, potassium, but also the calcium influx. The calcium influx is also we have know that also need to the deposition. So here, based on this, we think about the first that maybe the signal arterial node during the phase the automatic abilities is higher than the Purkinje. Yeah, I hope you know that. Okay, and then based that I also that this there's no rate of the elevation and there's no rate of the deposition in the phase 4. So we can see here if the phase 4 the rate the action open the snow and then this phase 4 ultra deposition is no rate of that. Yeah. And we can see here this immediately that the Purkinje cell then we can see here action potential. There is also during the phase 4 the automatic deposition and then reach to the threshold potential and then the deposition fast and also there are 0, 1, 2, 3, 4. But also there we can see here during the phase 4 phase 2. No obvious the plateau period. Yeah. Okay. And then we have know that we can know that according to the rate of the deposition in the phase 2 phase 0, and then we can be classified the cells fast response and the slow response, and also the absence persistent or absent of the automatic deposition in phase 4. Then this cells can be classified the automatic cells or non-automic cells. And also then I hope you know that this we can see here that this like that. Can you tell me the green? The green wave? Can you tell me the green wave? You think about according to that? You think about this cell which type? Green. Yeah. Who can tell me? This is action potential. This action potential wave. The green. Can you tell me this cell which type according to their which type? Hmm? Who can tell me? Fast response non-automatic cells. Very good, Li Yinjie. Thank you. And then we can see here, according to the zero phase, we can see here this fast. We can see here this is the deposition very fast. And also then during the phase 4, we can see here there's no automatic deposition, and also then we can stable in the resting potential. So here that this cells is the fast response non-automatic automatic cells. Yeah. And also then we can see here that like that yeah, the red The reactor you think about that which type? Yeah, the reactor which type? No, or the yellow. The yellow you think about which type? Who can tell me? This yellow curve, which type of the cell? Hmm? This yellow curve, you think about which type?
Fast response autonomic cell.
beg your pardon.
Fast response autonomic cells.
First slow or fast? Hmm? We see this curve first. You think about that the zero we can see here is slow or fast. Yeah.
Slow.
Very good, slow. And also then we can see here that the phase 0 is slow. Phase 4 we can see here this automatic or non-automatic. Yeah, phase 4. Phase 4, who can tell me? We can see here the phase 4. Automatic, very good, Li Yinjie, thank you. And then we can see here also that we see the wave. We can first think can see that we can see here this phase 0, the phase 0. We can see here slowly because we can see here the need more long durations or long time. And also then we can see deposition aptitude is also lower than the ventricular mad cells. So here we think about that this is a snow response. And also then we can see here that the phase 4 is not is unstable and also can automatic deposition. So we can think about that this is the snow response and automatic cells. This so here that according to that we also know that this is majorly that this we can see here this is the signal atrial cell node cell. Then certain signal are not signal atrial node cell is the kind of the cell is that the snow response and automatic cells. Yeah. Okay. And I hope that we first that if we this classification the basic mechanism, and then I hope you understand, and also then this you will often see these questions do many exams. I hope you according to this wave you should understand and also remember, and also I hope you not remember wrong, and they are according to the phase theory. Phase theory, fast or slow, and also the different channel, and we can classify that the faster response and the slow response, and also the phase 4. The phase 4 can position or absent of the automatic deposition. We can be classified that the automatic cells or non-automatic cells. Yeah. Understand here?
Yes, Lauscher.
I hope you understand and remember. Yeah. And also then we talk about that the first response or slow response, and because the channel open different type channel, and the fast response cells majorly because the faster sodium channel open, and the slow response cells because the slow calcium channel open. So here there are I hope you know that the fast sodium channel and the fast sodium channel and the slow calcium channel. And then we can and also that this the fast response action potential and the slow action potential. And also that the comparison of the transmembrane potentials and the mechanism between the ventricular and the sinus node or the sinus arterial node PCLs. This mechanism we have studied that majorly that, and then first that the fast sodium channels. Fast sodium channels and slow calcium channels. The fast sodium channels that we have faster activation and also faster deactivation. About that, this is the threshold potential is negative 70, and also slow action activity and also slow inactivity, and also that this threshold potential is negative 40, and also then phase zero depolarization that in the ventricular myocyte, and this is the major that the single arterial node T cells, and also the fast sodium channels. The blocker is like that we have known the TTX, and also then the sodium channel open blocker is M, and also the visual penny. You know that okay, and also we have that the ventricular myocyte and single arterial node PCLs. We compared that reacting potential. Then according to the ventricular myocyte is the reacting potential. According to the single arterial node PCL is not the reacting potential. This is the maximum diastonic potential or the maximum the utilization potential. And also then we can see about that is negative 70, and this reactive potential negative 90. And the threshold potential is also different. We can see here. And phase zero depolarization victory, we can see here fast and it goes slow. And also the memory potential at the end of the phase zero is about, we can see here is positive 30, and there is zero. And the single arterial still node is the no reverse polarization. Yeah. There I hope you according to that I hope you understand that okay. And also the mechanism also there we have talked about that this is the ventricular, and also that this single arterial node we can see there phase zero and phase one, 2. But there are no phase 1, 2, and there are phase 3 and phase 4. Yeah. Here I hope you understand. According to that, I hope that master the transmembrane potentials and the mechanism of the majorly that this is the ventricular myocyte and sinus node. Yeah, and then this major knowledge about this is the kept. I hope you understand and remember. Okay. Yeah.
Okay, Lauscher.
Then we know that the action potential produced also action potential is the mark of the cells excitability, and excitability, and also then also need to the we have no excitability, and then this excitability, and then need to the because this calcium open the channels open or the channels closed. The channels open or channels closed, and then because the channels the channels we have known that have majorly that the three situation, also that the evaporation, also the close or the open, and also then so here that the when the cells during the cells the exalted, and also then one stimuli. This stimuli imagine that the signal arterial node PCOs the automatic ability, and then this exalted this the exalted and the conductor to all the heart cells, and then one automatic exciter, and also need to the one excited and one compare one automatic stimuli, and also one the action potential. But then we have know that the cells after one also that we have know that they are changed during that. We can see here that the physiological properties of the myocardium, and also which force that the excitability. All the cells, all the myocardial cells have the excitability. Then the excitability, and then it means what is the excitability? It means that these cells can be produce the excite or produce the action potential, and then these cells we know that these cells have the excitability. Then excitability we can see here. This like that. This is a ventricular action potential. Then we can see here, and then during this like that we can see here. This sodium can you tell me the basic this action potential produced majorly because that which type the channel open? Who can tell me? This ventricular action potential. Then ventricular action potential produced majorly the basic channel. Which basic channel open? They need to this cell produce the action potential and have the excitability. Very good, Li Yinjie, thank you. That's the sodium influx, and then reach the threshold potential, and then sodium influx, and then need to this the major and basic the action potential produced. So here, and then also we have known that the sodium channel can be open and or closed, then be regulated the membrane potential. So we can see here during this period, we can see here that this sodium, according to this, we can see the sodium channel open or close. Who can tell me? During this period, who can tell me this sodium channel open or close? Close, very good. And we have known that the sodium channel can be regulated by the membrane potential, and the membrane potential, and also then during this period that the sodium channel is in activity, and any change and any stimuli and cannot need to this the sodium channel open, and also cannot need open, and means that during this period these cells have not the excitability, So we can see here that the periodic change in the excitability of the myocardium cells, and then according to their this curve. This curve is the this means that the muscles, the myocardial muscles contraction. This is contraction curve. We have known that one excitability and the one excitability and one contraction, and we have known that this excitability and excitability contraction company. So here that and first that this period we call that ERP. ERP is the effective period. We call it the ERP. During this period, that this is the myocardium cells haven't the ability, haven't the excitability, and then what is the effective period? And also then this is also different from the skeletal muscle. We have known that because this is a the phase 2 plateau period, and then this lead to that the ERP have a non-directions. Yeah, ERP. ERP it means that Chinese name 有效播音期. It means that effective infection period ERP. And this definition that the myocardium cannot generate new action potential during this period, from the start of the phase 0 to the recovery of the membrane potential to negative 60 in phase 3. It means that from the phase 0 to the phase 3, the membrane potential recovered to the negative 60. During this period, then this myocardium cannot generate new action potential. It's because that during this period, the sodium channel inactivity. Yeah. The feature that this effective ERP have a non-directions. Non-direction about we can see for 250 and 50, and then ensure that this myocardium cell will not have the tonic contraction. Have not have the tonic contraction, but skeletal muscle can have the tonic contraction, but this myocardium haven't tonic contraction. It's very important. And we have know the myocardium contraction is very important to the heart, the ventricular bump, when they bump. And then myocardium still haven't the tonic contraction, and then can lead to the ventricular bump function normal, like that the contraction or relaxation. Yeah. And the reason that because that the negative value of the membrane potential is too small, and all the sodium channels are inactivity, or only a few are inactivity. Majorly that inactivity, the sodium channel are inactivity. And this combination that absolute effective period and local reactive period. Yeah. Have a rest, okay? Good boys, we'll have rest, okay?
Sure.
Okay. 10 minutes later, we will continue. Have a rest.
OK，老师。
谢谢。 Okay, boys and girls, come here. We are continue.
Okay, okay.
Yeah. And then I hope that what is the effectory the period? We call that ERP. And this definition, I hope you understand that. First, that you should know that the period from the start of the phase 0 to the phase 3, between the phase 0 and the phase 3. The phase 3 is that the membrane potential recover to the negative 60. During this period, the myocardium cells cannot generate new action, doing new action potential. And this period we call that effective effection period. And then cannot generate new action potential. It means that during this period that these cells, can you tell me during this period? Can you tell me this the myocardium usability is higher or lower or yeah? Can you tell me? During this period, then according to Zio, we can see here the myocardium usability is higher or very lower. Yeah.
No.
No, very good. And also then I hope you know that during this period, the very low, and also we call that this is during this period, during this EIP, the myocardium usability is zero. Is zero is very low, and zero it means that very high the stability cannot lead to this myocardium cell get new action potential or can usability. Yeah. And also then the feature reason majorly that all the sodium channels inactivity, and we have known the sodium channels should in the activity or recovered, and then can be reacted, can be activity. And then these all sodium channels are in the inactivity situation, and then their cell during this period that the myocardial cells have no the usability. And also then this effective ERP be made up of the absolute effectory and the period and local reaction period. And then we have know that the cyclic changes in the ventricular usability, and is that this during this part the ventricular usability change that this periodic change include that the EIP. The EIP is being made up of the absolute effectory or the local reaction period. And followed that is a relative refractory period, and RRP, and also that the actual ordinary period. And also that then the EIP, during the EIP that we have known that this is during that the depolarization to the depolarization that the negative 60. And then this cannot be generated that because majorly that all the sodium channels is inactivity. And we also can be classified the absolute refractory and local reaction period. This to be made of the ERP. And also then relative refractory period, then because some of the channel sodium channel are most recovered. We recovered and recovered. We 70 at the about the negative 80, and then this during this period can produce a new action potential, But that this the is more than normal. And also, then there is extraordinary period. Then the sodium channel based on return to the normally all the recovered, and then this is the same as the relative factory period. Yeah, this is clinical change. The cycling change in the ventricular excitability I hope you understand that, that especially that ERP. I hope you understand. And also then, during the ERP, that is the ventricular instability is 0. Yeah? Understand here? Here, I hope you remember and study this, compare the skeletal muscle cells, the instability change. Yeah. Okay. And then here that I hope you understand that ERP. Okay. And then there are that the factors affecting the cardiomyocyte instability. And this cardiomyocyte instability can be affect that majorly 3 types. First one, that the resting potential, or the according to the ventricular is resting potential. According to the automatic cells, there is a maximum utilization potential. So here that first that the cardiomyocyte instability can be affect the resting potential or the maximum utilization potential level. And we can see here that when then we think about the ventricular myocyte, we can see here that then like this one centimeter, 2 centimeter. Then can see here that if the resting potential, this one level, the second level is I'm sorry, this S1, this is S2. Then can you tell me? There also that this threshold potential is the same. There about the threshold potential about the negative 70. And then we can see here S1 is also the normal like that. We have normal the ventricular, the resting potential is about the negative 90. And then if the resting potential decrease it means that we have talked about that the immediately that the absolute potential decrease. We call that. Then we can see here that this is the resting potential up. And then can you tell me that if the according to the S2, the resting potential is also resting potential is a large. Yeah. Who can tell me S2 or S1? You think about that. Which situation the myocardial excitability is higher? Yeah. Who can tell me? You think about according to this curve. You think about that. I hope you think by yourself that which one or two situation, which situation the excitability is higher?
S2.
This is 2. This is 1. Who can tell me? Pardon?
S2. S2.
Li Yitong, can you tell me 2 or 1? Which is higher excitability? Very good. Li Yitong, thank you. Then is that then there's S2. Yeah, S2. And then why the S2? And the easy to understand. And then we can see also that if the S2, if the resting potential decrease, and then also that we can see S2 is near to the resting potential. Is near to the resting potential, and also we can see here that and he should receive the lower stimulation, and then easily need to reach the resting potential, and easily to produce the action potential. And also then we have know that easily to also that this the aptitude of the stimulation is lower, and then this CL's excitability is higher. So here, and then comparatively, if that according to the S2, we can see S1, the negative value is increase. Also, it means that resting potential increase, and then the S1 distance from the resting potential is longer, is higher. We can see is higher. Actually is higher. Higher is that means that the stimulation intensity You can't to induce the excitability is increase. Then increase also we know that it means that then need to the excitability decrease. So here that I hope you understand that according to the S2, if the S2 is normal, and then we can see according to the S1, we can see here S1 is the negative value of the resting potential increase. Then increase, then we can see here the S1. S1 far away the threshold potential, threshold potential is the distance from difference from the potential is higher. So here is higher. It means that he need more higher intensity of the stimulation, and also that its stimulation intensity required to induce excitement. So here excitement it means that action potential. So here this shows the excitability decrease. The higher threshold stimulation, and also the excitability decrease. Yeah, understand here?
Yes,
Do you understand?
Losha.
Yeah. And also the second that this force that the resting potential will affect the cardiomyocyte excitability. And then we have know that we have studied the resting potential. We have know that the resting potential can be affect which factors. Yeah, we have studied chapter 2. We have studied that resting potential. The resting potential can be affected by many factors. The major factors, do you know that? Yeah? Who remember? Remember the resting potential level. The level of the resting potential can be affected by many factors. Then can you remember which factors will affect the resting potential level? Hmm? Who remember? So here we studied that this is the chapter 4 the excitability or the by the cardiomyocyte by electrical activities. I hope you compared we studied the chapter 2. Chapter 2 the cells excitability, resting potential and the action potential, and then the chapter 2 we majorly studied that the skeletal muscle or the nervous cells, and then only we compared, and then we easily to understand, and also we found the different. Yeah, and also then who can tell me that the resting potential level can be affect majorly that potassium concentration in the blood? Do you remember? Do you remember? So here after class, I hope you view that the resting potential levels be affected by the many factors, and there are major factors like that the potassium concentration in the plasma, and if the potassium concentration is higher or lower than normal, like that hyperkalemia or hypokalemia, and hope you think about that this question that during the hyperkalemia or then the resting potential level have the change of the resting potential, or the hypokalemia and that the resting potential never have changed. Okay? Yeah.
Okay, Losha.
Okay. And also that based that I hope you think about yourself that if the hyperkalemia or the hypokalemia, then the myocardial instability how change of the myocardial the instability. Yeah. Oh, this is very important. I hope you think after class you do these questions by yourself. Yeah. Okay. The first that the resting potential will affect the cardiac myocyte instability. And the second that the threshold. The threshold potential level. The threshold potential level, we can see here that this is the resting potential doesn't change, but that this 1, 2 threshold. And also we can see here that this is 1 threshold, 2 threshold, and who can tell me which threshold is a higher stability? Yeah. Who can tell me? You can see here the threshold, 1 threshold, 2 threshold. Then can you tell me the resting potential doesn't change, only because the threshold change. And then can you tell me which threshold level the instability is higher?
杜老师
2. Yeah, very good, very good. And also we also can see here that this is 2 threshold, this 1 threshold. Also we can see the distance between the two threshold to the resting potential is the distance is lower. And also then we can see this is the distance from the 1 threshold is higher. So here we can see here if the threshold level moves up like that 1. And we can see here distance from the resting potential is increase, and then we can see here then need more intensity stimulus. So here that the stimulus intensity required to induce the excitement. So here this instability decrease. And also we can see here that this threshold can be affected that the majorly that the cells, if the cells majorly that the channels activity, and if the channel activity can be affect some many drugs like that the blockers. Yeah. Okay. This is the second factor. And the third is that we can see here that like that we talk about that because the sodium channel situation, and then can affect that the myocardial instability. So here that we can see here that during the different ion channels properties that cause further cell rate deposition. And we can see a faster response cells, the sodium channel. The slow response channels cells like that, the L-type calcium channel is also the slow channel. And also we can see here that we can see complete up the activating and deactivation, and also just recovered and gradually. We can see here different type. We can see here like that during this ERP, this absolute infection, also the local reaction is total. We call that ERP. During this ERP, because the sodium channel is inactivity. So here that this inactivity, and the one can see here this is during this period the myocardial cell instability is no instability. So here there, and also then the relative refractory period, and then is no instability, and also then the actual additional period is higher instability. Yeah. Is then this means that this also that ion channel properties that cause the phase zero depositions. Then this channel situation also can affect the instability. Yeah. So here that I hope you understand that immediately that this is three aspects, three factors affecting the myocardial site instability. Yeah, understand here? Do you understand?
Yes，老师明白了。
Yeah. Especially, I hope you know that resting potential and the sexual potential also affect that. Yeah, and also then we have know that we just about that this is the action potential or ventricular contraction is majorly that the heart contraction. And also we can see here that one action potential and one contraction. Yeah. And we have now the one action potential is then action potential the contraction compounding. So here we have studied the skeletal muscle is also the same, they can. And then we can see here then because this is EIT produced. So here we have know that during this period, any stimulus cannot lead to produce the new activity. So here no new activity, no new action potential, and also no new contractions. So here that we have know that then according to the Mercator site, we can see here then no tonic contraction occur. And because why the ventricular contraction haven't the tonic contractions occur because there's a longer effective factory period. And so here this period we can see here this period very longer. We can see here this curve the red curve we have now that during this curve, can you tell me this stage which can you tell me? This curve we can know that this contraction curve contraction curve be made up of that this stage. Can you tell me what we call that situation? This stage. Yeah. Do you know? We have studied that the chapter 2. We have know that this contraction curve. This contraction curve, can you know that means that this is the tendency during this tendency increase. In tendency increase, then we call this curve, this stage. What? Who know? Hmm? This stage, do you know? You forget? Yeah. This red curve, do you know this red curve, this stage? From here to here. Do you know? Simei, are you know? Do you know? Simei, are you here? Simei, are you here? Yeah. Nini, are you here?
Yes, 老师。
Then can you tell me this stage? Nini, can you tell me this stage we call that which situation? This stage. Hmm? We have know that this curve is the contraction curve. Contraction curve include that this stage we know that this muscles is contraction, and the contraction this stage we call that cytonic period. Yeah, and also then this stage there we call that muscles relaxation. Then relaxation we call that diatonic period. Yeah, you forget?
Yes, 老师。
Okay, and then we know that then we can see here this muscles contraction that this muscle contraction that this contraction period we call the syntonic period, and this is the highest amplitude, and then after the highest amplitude, and then during this period we call that is the diatonic period, and then we can see here the ERP. The ERP, according to that, we have know that one action potential and also one contraction. And then this ERP very longer. The longer we can see here longer lasts the until after the systolic period. And then we can see here this lasting until earlier diastolic period. Like that, we can see here. Is also that is about that 250 millisecond. We can see here. Then it means that ERP, according to the ventricular, because the ventricular action potential, ERP very longer. The longer that lasting until to earlier diastolic period. So here, during this period, we give a new stimulus. Then can you tell me there is no a new action potential produced, and also there is no a new contraction. So here we have know that there cannot happen the tonic contraction. Understand? Tonic contraction it means that first that this dimension need the new action potential and the new the contraction, and then even the muscles cannot relaxation and even the contraction. But that according to the heart, there are no tonic contraction occurs. Yeah, understand? Do you understand?
Yes, Lasha.
Tonic contraction is means that is this contraction is also keep the contraction, no relaxation, because the stimulus is the stimulus more stimulus and then produce more action potential, and also need muscles contraction. But that we have now according to the myocardial cells, their ERP is very longer. And also they need to that the higher last until the earlier diastolic period. So here, if there are a new action potential during this period, this new situation period, but no new contraction produced. And then so here that I hope you understand why the myocardial site cannot tonic contraction, because that have a non-effective effective period, and also there this period lasting until earlier diastolic period. Yeah, understand here? Do you understand here? Okay, and then we have know that in the clinic, you have heard that I think about is that you in our in the clinic work there's a disease like that the premature beat. Do you know? Premature beat. Do you know? Do you know this disease? You have heard the premature beat. Do you know? Yeah. You know that you maybe you don't hear that, and there I hope you know that we can see here like that this myocardial cell contraction curve. We can see here this condition, and also that this is the action potential. Also we have this is this sinus rhythm. Is also that we have know that our heart is our heart rhythm is be controlled by the sinus arterial node P cells, and then we call the normal rhythm. Normal cardiac rhythm is actually the sinus rhythm. You know that, okay? And then we can see here that this normal sinus reaction, sinus rhythm, and 1, 2, 3. We can see here this follow the unit, also the unit. We can see here, and also then we have know that our heart normally be controlled the rhythm be controlled the rhythm of the signal atrium not the cells, because the signal atrium not the P cells have the automatic rhythm. We have studied that we know that. And then we can see here, and this is normally the normal. We can see here, this is one activity, and also they need to the one action potential, all the heart, and also so the all the myocardial cells the activity rhythm is be regulated by the signals. And the signals, we can see this signals, and we can see here the myocardial contraction curve. We can see also the rhythm, by this rhythm be regulated by the signal atrium node. We call that this is the heart rhythm. We call the sinus rhythm normally. We can see here this is normal. This is normal. And then like that, we give also we give actual stimuli. Actual stimuli may be like that to the heart, maybe some of the materials and some of the chemical materials affect the other automatic cells, and they need to this other automatic cells activity, the automatic rhythm change, and then like that is actual stimuli. We can see here. Then this actual stimuli during this period, we can know that because that the heart is ERP, the cardiac myocyte is ERP. Yeah, when can see here, this actual stimuli is in the ERP. During the ERP, we have know that they cannot produce a new action potential, and also we can know there's no. This means this actual stimuli is not effective. We can see here like that. This is also that. Yeah, but then we can see here. And then this actual stimuli happened after the ERP. After ERP, and then after ERP, we can see here this after the ERP doing that like this. Then after ERP is RRP, and also then we can see here this a new or actual stimuli, and then can lead to this because the sodium channel recovered, and also they need to can produce a new action potential. A new action potential also can produce a new contraction curve. So here that we can see here that this is the stimuli after the ERP, and then can produce a new action potential, a new contraction curve, or contraction. A new contraction curve, we can see here this contraction is the same the rhythm channel, sinus rhythm. Yeah, this contraction curve, this contraction is different the sinus rhythm. Yeah. Understand here? Do you understand here?
明白的，老师。
So here, this contraction, we call that the premature systole, and it means that after EIP of the ventricular muscles, that before the next sinus, we can see the next sinus node excitation arrives, and then during this period, we can see here, then the after effect after ERP, this you can see here is after ERP. But this stimuli before the next sinus node excitation arrives, and also then the ventricular can be excited and contract in advance by external stimuli. Then we can know that this stimuli is after the ERP and before the next. We can see the next sinus node excitation. And then during this period, then this stimuli is effective, and then can produce the new action potential, and can produce the new contraction. This new contraction, and also we can know that this contraction is also different from that the sinus rhythm contraction. And this contraction we call that premature systole. and systole, premature systole, and also need to that the contraction, and need to that the heartbeat. And this heartbeat we call that the premature beat according to the heart. So here in this disease, you should know that premature beat is because that this actual stimulus and they need to all that. But there we have known that cannot produce, and only that produce one this beat. And this beat we can know that this beat, and also this contraction also is a new action potential. A new action potential we have all known that this new action potential also have a non-ERP, also have a non-ERP. The ERP because the ventricular muscles. And also then we can see here that the non-ERP, and also then we can see here this next the sinus node is activating just doing the ERP, this action potential ERP, and also then this cannot lead to the this myocardial cell cannot produce the action potential. So here we can see here this is not effective. So here we can see here also there is a longer, and then we call this longer time. We call that because that a long period of the ventricular diastole is often followed by the premature style or pre-style. Premature style before sinus rhythm is restored. We can see here, and then also that this we call that the compensatory pause. So here, and also then we can you call the ECG. Also we can find that this change. We can see here that like that ECG curve. We can see here. Then this is we can see here that this is the normal stimulation action potential is from the sinus rhythm. We can see here that. But we can see here that this rhythm channel open. We can see here that lead to the action potential like that ventricular action potential. We can see here, but then extracellular stimulus. This red is we can see here like that. This is doing the ERP. They cannot produce a new action potential, and no new action potential, and also no contraction, and also that we can see here. No another the ECG wave. But in here we can see here this extra stimulus after the ERP, before the after ERP, before the sinus node excitation. We can here they are lead to a new action potential. This is a new action potential. The new action potential and also produce a new contraction curve. And also then we can see here new action potential, the total all the myocardial cells action potential all have a new action potential. We can see here there is a new ECG. We can see here ECG. And ECG we can see ECG curve. And also then and after there we can see here this action potential also have the ERP. And we can see here this is the normal sinus excitation. During the ERP, also they cannot produce action potential. So here there's a non-directions. We can also can be seen the ECG curve. There is a long period or directions, and also then we can see the normal stimulus rhythm. We can see here the ECG, the action potential, also the ECG, the normal ECG. So here we can record the ECG. Also, we can found the premature beat or premature cycle or premature. Also, we have found the disease that premature beat disease. Yeah, understand here? Do you understand here?
Understand.
Okay.
Yes, Losha.
I hope you understand here that when you are doing the clinical work, you understand you should have to find the premature disease and to find, and then you should know how to record the ECG. You should ask the patient to record the ECG, And also you, as a doctor, you know how to see the ECG, and then we also we this ECG we can see here this curve found, and you should know that the premature beat happened. Yeah, and also that this I hope you understand that. Yeah, and then also that the premature systole and also the compensatory pause. I hope you understand that. And then also we have know that the contractibility of the heart is first the perpetuals, and also the second the conductivity. Conductivity, you have know that we can see here that the pacemaker of the heart is majorly that the sinus node. The sinus node we can see here. Also the heart action potential or the heart rhythm be controlled the sinus node. And also that we have known that all the heart, the myocardial cells instability because the sinus node. So here the sinus node, all the sinus node, sinus node, the action potential produced because the phase 4 can automatic rhythm, and also then he can conduct all the myocardial cells have the conductivity, and all the cells can conduct the action potential like that. During the atrium, there is a dominant pathway. Also, the dominant pathway is also very quickly. We can see also the left heart or right heart is very quickly then conduct the action potential to this atrioventricular junction. Then the atrial myosite, and also that atrial myosite, and also they need to that the action potential produced that conducted by the atrioventricular bundles, and also like the left bundles, left bundles or right bundles, and also that be conduct the Purkinje fiber, and also the ventricular muscles also have the conductivity. We have known that all the cells, all the myocardial cells have the conductivity, and include the conductivity. And then I hope you know that the conductivity of the excitement in the heart. We have studied that this action potential be conducted between the cells. Between cells, this is the heart. We have known that the heart cells, between the heart cells, there is a gap connection. We have studied chapter 2. We can see here that this is a gap connection. Gap connection that we also in the heart we call that intercalated disc. In the calated disc also challenge them 运盘. And this gap connection is majorly that the action potential conducted by the current, the electrical current. Electrical current is very fast. So here we can see here that normally the total heart right, the total right atrium or the right contraction, right the ventricular. We can see here right during the action potential be produced by the sinus node, and then the atrium muscles at the same time excitation. Also that the ventricular or the ventricular myosite is also at the same time excited. So here we call that this is that that we can know that this is the conductor, majorly that in the heart, very important the structure that intercalated disc. Can you see this disc? Yeah. This is one cell, the two cell, and the second cell. We can see here there between the two cells there is the gap collection. This gap collection in the heart, we call that this is the intercalated disc. Yeah, this calated disc can be needed to the this action potential conducted to another cells. It's very fast, and also then lead to the total heart, the total atom or total ventricular is the same time activity. Yeah, understand here? Do you understand here?
Bye,
Okay.
Lasha.
Yeah, this class we will talk about here. Tomorrow we continue. Okay, goodbye. I hope you view this PPT, and also then we can in the class we can discuss together. Okay.
谢谢老师，
Goodbye.
谢谢老师，再
谢谢
见。
谢谢老师，再见。
再见。
谢谢老师。